questions over all of the administrative information I just covered? Is everybody okay with that? All right. Okay, excellent. I didn't hear any major complaints, or I'm not seeing anything. So hopefully everybody's okay there. All right. So now what I want to do is I just want to roll in and just pivot right into talking about electrophysiology, which is an amazing subject. And it is so incredibly detailed. It's just like pharmacology in that I'm only going to be able to scratch the surface. And so I'm going to go for the high yield concepts. It's going to feel very difficult and very detailed at times. But the field of electrophysiology is vast. It is a vast, deep abyss of knowledge. And there are actually cardiologists and cardiothoracic specialists that spend their entire lives specializing in just the field of electrophysiology. And there are actually many unanswered questions to this day. So it's incredibly detailed, but it is an critically important field to have a basic appreciation of, particularly as it pertains to us in the emergency and pre-hospital setting. So with that, what I'm going to do is I'm going to stop my video here. And I just want to do that in order to shunt as much bandwidth as I possibly can into the other visual and audio components of this. And we'll see how that works. All right, so what I'm going to do is I'm going to take over with the iPad here. Before we actually start talking about electrocardiographic interpretation, we need to talk about the physiological foundation for everything. So that's what I'm going to do right now. So let me bring this up. All right, so this is your introduction to electrophysiology. So real quickly, the anatomy and physiology of this, let me just zoom in here. All right, really starts in the heart. And when we look at the heart, notice a few things. We look at the histology of the heart, you notice that the heart, the majority of the heart, the middle part of the heart, we call the myocardium, is full of these branched myocytes. So these are branched striated cells. These are special kind of muscle cell called cardiac muscle. You've got smooth, cardiac, and skeletal. And this is branched and striated and has multiple nuclei in them. And the striations, of course, are the thick and thin filaments of the actin and myosin responsible for the contraction. We talked about the sliding filament mechanism for muscle contraction earlier. We will reference that again here today. And of course, you have these structures called intercalated discs. I'll circle them in yellow here. And these intercalated discs connect the individual myocytes, and they have little gap junctions in them, little pores that allow sodium to travel. And so what that does is that allows one myocyte to immediately communicate to another, and that allows for the wave of depolarization to move through the heart rapidly and to move through the heart in an ordered way that allows the cells, the individual cells of the heart, to function as a single unit, if you will. So there's a very complex flow of ions that is able to allow the heart to function as a unit. So that's what we see when we look at the cardiac muscle. And of course, these individual cells are referred to as myocytes or muscle cells. All right. And so it all starts with depolarization, right? And this is for muscles in general, right? So a muscle gets stimulated typically by the central nervous system, although cardiac muscle has special properties where it can actually stimulate itself. It does not need the nervous system to tell it to depolarize, right? For example, skeletal muscle, for the most part, requires the central nervous system to interface with it and to control it. Whereas the heart, you can completely detach the heart from the nervous system, and the heart will continue beating on its own, or rather, it will continue having its own electrical activity. And we actually see this in people that have heart transplants. If you have a heart transplant, that newly transplanted heart is not connected to the nervous system, but it's able to regulate itself. And that's one of the four special properties of cardiac tissues. And that is called automaticity or rhythmicity. And that is the ability to generate its own impulse. Now, there are things that can increase or decrease the automaticity of these tissues, of the myocytes, but they are still able to generate their own impulses or their own action potentials, right? And then, of course, the nervous system can increase or decrease the automaticity, or underlying disease and electrolyte imbalances and other pathologies can impact automaticity. These cells are also able to conduct these impulses. That's called conductivity. The muscles are able to contract. So we say they have contractility, right? And they are excitable, right? They have excitability. And so they can respond to external changes, right? If there is an increased load put on the body, and there are various chemokines that get released by tissues that are under load, the heart may be able to sense that and increase its rate or contractility. Another term for increasing another term for contractility is what we call inotropy. And so you may hear the term positive or negative inotrope, right? Drugs that are positively inotropic, for example, increase contractility. Negative inotropic drugs decrease contractility, right? Conductivity. Conducting impulses. Another word that you're going to see for conductivity is something called dromotrope. Dromotrope refers to the speed of conduction through tissues. And there are certain things that can increase, positive dromotropes, increase the speed of conduction. And there are other things that can decrease the speed of conduction, or we call the conduction velocity. So inotrope refers to contractility, chronotrope refers to the rate or the automaticity, and dromotrope refers to the conduction velocity. And I should say, under normal circumstances, the speed of conduction is much faster in the ventricles. In fact, it is substantially faster because most of the tissue of the heart is in the ventricles, right? And so it makes sense that you need faster conduction through the ventricles, whereas the conduction velocity is generally going to be slower through the atria, the top part of the heart, because there's less tissue that needs to be depolarized and repolarized. And so it will conduct slower through the top part of the heart and faster through the bottom part of the heart. All right, so let's move on and talk about depolarization. So depolarization in most of the tissues, in the contractile tissues, in tissues that can actually contract, is primarily going to start with sodium. All right. And so what happens is you've got the sodium potassium ATPase pump, and its primary job is to pump sodium out of the cell and pump potassium into the cell. And so the resting potential of cells that have the ability to generate action potentials is going to be sodium outside and potassium inside. And then when sodium rushes into the cell, we say that it depolarizes. A lot of positively charged sodium comes in and it depolarizes the cell. And then you have a flow of potassium out, and that's primarily what's responsible for repolarization, right? And we talked about this in pharmacology. We talked about the cardiac action potential. So let me zoom out here again. All right. So the way that these tissues depolarizes differs slightly. We talked about this in pharmacology. In the pacemaker cells of the heart, right? For example, the SA node, which is the primary pacemaker of the heart, these are primarily going to be calcium based. And so what you get is in phase 4, you get a slow flow of sodium. These are always permeable to sodium. And so you're going to get a constant slow trickle of sodium into the cell until you reach what's called the threshold potential. And there are channels that detect the change in the potential, the voltage potential, as sodium is moving in. And once the threshold is met, then what happens is you have all of these channels. They're referred to as voltage gated. These are referred to as voltage gated channels will open up. In this case, these are going to be voltage gated calcium channels. Calcium then rushes in, depolarizes these nodal tissues, and then that's phase 0. And then in phase 3, potassium begins leaving, right? And so you have positive charge leaving, and so the potential will decrease and become more negative until you get back down here to this little valley down here, which is very low. And then you get a constant flow of sodium back in until you reach threshold, and it depolarizes again, and so on and so forth. That's what we see in pacemaker cells. Now, in the ventricular tissues, which are not good pacemakers, phase 4 is generally flat. There's not a whole lot of sodium flow into these cells. These cells are generally impermeable to sodium. That's not entirely true, but it is at a functional level, at a practical level, it is practically true that there isn't a whole lot of sodium flowing in. So phase 4 is very flat until these tissues are stimulated. And these get stimulated by the nodal tissues. So these pacemakers are depolarizing like this. And when that wave of depolarization gets to these ventricular tissues, these contractile tissues, that wave of depolarization will cause the sodium channels to open up. So in ventricular tissues, it's a flow of sodium. Sodium rushes into the cell, depolarizes it. And then up here in phase 1, you have potassium starts leaving, but calcium starts coming in, and that causes it to flatten out. And then in phase 3, potassium continues leaving as you repolarize, and then you get back to phase 4, resting potential. All right. And we talked about this already in pharmacology. A critical concept that comes from this, however, is something known as a refractory period. The refractory period is a critical period of time where these tissues cannot respond to another impulse. And there are two components of the refractory period. There's something called the relative refractory period and the absolute refractory period. And what we are most concerned about is phase 3 right here and phase 3 right here, right? During phase 3, this is what we call repolarization. Right? The potassium's leaving and the membrane potential is becoming more negative, right around 100, negative 100 millivolts for ventricular tissues, and like negative 30 or 40 millivolts for pacemaker tissues. All right. Repolarization is right in the middle of the absolute refractory period. And if the heart gets stimulated during the absolute refractory period, that can cause something known as an R on T phenomena, right? Where you get stimulation occurring at or near the T wave. And I've drawn this for you all. The T wave roughly corresponds, let me zoom in here. The T wave roughly corresponds to phase 2 and phase 3 of the cardiac action potential. This is a very critical time. And so if you stimulate the heart during the T wave, that can cause the rhythm to deteriorate into a life-threatening rhythm: ventricular tachycardia, ventricular fibrillation, torsade, which is a type of ventricular tachycardia, and so on. So this is where what we call premature complexes play a role. And premature complexes are premature depolarizations that occur, and they can occur high up in the heart or low down in the heart. And what happens is, the closer a premature complex gets to the T wave, the more problematic it can potentially become. And when you get premature complexes that are happening on top of the T wave, that is a more dangerous situation. This is also seen in certain types of external, I don't want to say trauma so much, but you can have external stimulation. And there is a condition known as commotio cordis, where it is more common. Actually, it is almost exceedingly common. That is to say, it's very rare that this occurs in adults, but it is much more common that this occurs in children, where a child gets kicked in the chest, or maybe they get hit in the chest with a ball, like a soccer ball, something like that. And it just so happens to hit them when their ventricles are repolarizing, and they are in their refractory period, and they get kicked or they get hit with a ball, and they just collapse into cardiac arrest. And that is why, because that impact happened to hit them on the T wave, which is occurring during the absolute refractory period, and caused them to instantly deteriorate into a life-threatening dysrhythmia. All right. This is why, and we will talk about this in more detail later on, but remember, in pharmacology, we talked about the QT interval and how a prolonged QT interval can be dangerous, because what that does is that prolongs this period of time here, right? This is the QT interval right here. And when the QT interval gets longer, that actually prolongs the absolute refractory period and makes it more likely that some weird stimulation can occur, either from within the heart typically, or sometimes without, that can cause this person to deteriorate into a life-threatening rhythm. So that's the problem with a prolonged QT interval, fundamentally speaking. All right. So before I move on, are there any questions over the basic stuff, the foundational stuff? Is everybody okay there? Okay. So before we move on, the next thing that I want to focus on, or I want to emphasize, is the following. Electrical activity in the heart is not always associated with mechanical activity. What you see on the monitor is not always a heartbeat. What you're seeing on the monitor primarily is the flow of ions into and out of the myocytes, sodium ions, potassium ions, and calcium ions primarily. You're not seeing necessarily what's going on under the hood. So remember, going back to this diagram of muscle here, the depolarization is only one part of it. And so what happens is, as the outer part of the muscle depolarizes, that wave of depolarization makes its way across the outer surface of the muscle until it gets to a structure called a T-tubule. And it's a little pore that penetrates down into the muscle. And that wave of depolarization makes its way down into the T-tubule. And there is a structure that contains lots of calcium on the muscle called the sarcoplasmic reticulum. And the sarcoplasmic reticulum, when it gets depolarized, it releases calcium ions. And those calcium ions actually act upon a binding site within the muscle. And we talked about this in earlier classes. It's known as the tropomyosin binding site. And that is the site that in its locked configuration prevents actin and myosin from coming together. Remember the sliding filament mechanism. Actin and myosin want to kind of pull together, but they're kept from doing that by this inactive bound tropomyosin site. And so calcium is released. It opens the binding site, and actin and myosin come to pull together, right? And that causes the muscle to contract. And then you have to pump the calcium out. And as the calcium gets pumped out, the tropomyosin binding site locks again, and the muscle relaxes, right? And so depolarization is what the sodium and potassium primarily that we're seeing at the surface here, and some calcium as well. But we are not seeing the contraction. In fact, when you see depolarization, the actual contraction of the muscle is going to occur slightly after what the complex you see on the ECG, right? So you're seeing the depolarization, and then hopefully depolarization will cause contraction, will be associated with mechanical activity, but not always. And there are special situations where you can have electrical activity and not have mechanical activity. So you've got depolarization, but you don't have contraction. And this is often referred to, if it is occurring in an organized way, this is something referred to as pulseless electrical activity, or PEA. We used to call it electromechanical dissociation, or EMD, but PEA is the contemporary term. So if you have organized electrical activity without a pulse, we call that PEA. Now, there are other times where you can have disorganized electrical activity that does not generate a pulse. That is not PEA. That falls into another category of cardiac arrest. And we'll talk about that a little later on. Okay, so I just want to make that clear, right? That what you see on the monitor is not necessarily the heart beating. It should be associated with heart beating, but not always. Okay, so let's spend some time talking about the cardiac conduction system. All right, so You have normal pacemakers, and when everything works, the primary pacemaker of the heart is something referred to as the SA node, the sinoatrial node. I'll circle that in yellow there. Oh, man, it's a substantial delay. All right, so that's the SA node. And the SA node is a group of a couple hundred cells or so. So it's virtually indistinguishable from the rest of the heart histologically. But it's a little clump of cells, exists in the upper part of the right atrium there. And it acts as the primary pacemaker for the heart. And it's automatic, it's preset automaticity in a normal adult is 60 to 100. So it will depolarize. Its preset depolarization is 60 to 100 times a minute. It will fire and depolarize. And then that depolarization is carried throughout the top part of the heart through what are known as the internodal pathways. And there are three major internodal pathways. There is the anterior internodal pathway that carries the impulse through the anterior part. It's hard to draw here, but imagine it going to the front of the top of the heart. So the front of the atria. This is also referred to as Bachmann's bundle or Bachmann bundle. Then there is a pathway in the middle that is known as the middle internodal pathway right here. That is also referred to as the Winky-Bach pathway. And then there is the posterior internodal pathway that brings that wave of depolarization to the back of the top of the heart, the back of the atria. And then that depolarization spreads throughout, depolarizes the myocytes, and hopefully those myocytes then can contract. All right. And then what happens is that depolarization gets held up briefly in this structure here. And this is the overall structure that I just circled is referred to as the AV junction. And the AV junction contains a couple of different structures. It contains something called the AV node. And then underneath the AV node is something referred to as the bundle of His. And essentially what it does is it conducts from the AV node down into what are known as the bundle branches. And the primary task of the AV node in the junction in general is to hold that wave of depolarization. So it allows for a little pause. And the reason that you need a pause is you need to allow time for the atria to contract, right? So you see them depolarize, and then you need some time for that depolarization to cause contraction. And once the atria contract, then that depolarization is allowed to travel through and down to the lower part of the heart, right? So it gets held up there in the junction, the atria contract, blood gets pumped into the ventricles, so the atria preload the ventricles, and then the signal, the depolarization is allowed to go down into the ventricles, and then the ventricles can contract and pump the blood out of the heart. All right. And from there, it will travel down what are known as the bundle branches in the septum of the heart. And you have two major bundle branches. You've got the left bundle branch and you've got the right bundle branch. So you've got the right one here and the left one here. I'll draw these little arrows. And then the left bundle branch actually has two additional branches to it. And these are called fascicles. So the left bundle branch branches out into two separate structures, or two major structures. It penetrates into the mainly the back of the posterior part of the left ventricle, and that's a structure referred to as the left posterior fascicle. And then there is the anterior part, which goes to the front of the left ventricle. And we call that the left anterior fascicle. All right, so the right bundle branch is just one structure that goes down the septum and then branches out into the right ventricle. But the left bundle branch further separates into the left anterior fascicle and the left posterior fascicle. And then eventually what happens is these pathways branch out into the ventricles, into what we call the Purkinje, the ventricular Purkinje fibers, or the His Purkinje, the distal Purkinje fibers out here. And that is what we see with the normal conductive pathways. All right. So we said the SA node is a primary pacemaker, but if the primary pacemaker of the heart fails, there are other areas of the heart that can take over as backup pacemakers. So if the SA node fails, the AV junction, if it is functional, can take over, but its preset rate of automaticity is much lower, right? Because it is closer to ventricular tissues. So the further down you go, the more ventricular-like, right? So the SA node is up here, and it is depolarizing like that, right? And then down here in the ventricles, the action potential looks more like that with a plateau. And then something kind of in the middle with the junction. So its automaticity is a little lower, and so it will fire at a slower rate, typically between 40 to 60 times a minute. And then if the junction fails, the ventricles themselves can take over as a pacemaker. But remember, their automaticity is very low. They are not particularly permeable to sodium. So it is much harder. Their automaticity is much lower. And so they will take over, but their rate is very slow normally at a rate of 20 to 40 times a minute. All right. And just as a reminder, the fastest conduction we see is in the ventricles. And interestingly enough, the conduction tends to be a little slower on the right side of the heart than the left. And the reason being is that there is more muscle on the left side of the heart. And so it will depolarize faster, and there's less muscle on the right side of the heart. So it will depolarize a little slower. And that means that both of them can depolarize at the same time, right? There's more muscle to depolarize on the left, so it has to depolarize faster, whereas there's less muscle to depolarize on the right, so it will depolarize a little slower. So the conduction velocity is a little slower on the right side than the left side of the heart. And that can get exaggerated in certain pathological conditions that we will talk about a little later on. All right, any questions over the cardiac conduction system? Everybody okay there? All right, excellent. All right, so this is, again, just a review of the cardiac action potential. So we're looking at this in ventricular tissues, right? So remember phase 4 down here. Let me do that in a different color. Phase 4 is the resting potential. Phase 0 is depolarization, sodium rushing in. Phase 1 is where it begins to dip down as potassium leaves. Phase 2 is a plateau where calcium starts coming in to offset the loss of potassium. And then phase 3 is repolarization, where potassium continues to leave until you get back down to the resting potential, phase 4. Now that's a little different in nodal tissues, right? So remember, in your nodal tissues, what you get is you get a slow movement of sodium in. And so you get this constant slope until you get to the threshold. And then you have voltage gated calcium channels that sense that change in voltage. They will open up, and then calcium begins rushing in to these nodal tissues. And then that's what you see with phase 0. So it's calcium, not sodium. And then potassium begins leaving. and it drops down. So you don't have that plateau like you see with ventricular tissues, right? So phase 0 is slower in nodal tissues as opposed to ventricular tissues. And that makes sense, right? You need to have rapid conduction through the ventricles so they can act as a unit. And there's really no resting potential in nodal tissues, right? There's no flat resting potential like you see in ventricular tissues, right? Where your resting potential is relatively flat. Resting potential in nodal tissues is there's always a slope there because there's always going to be some sodium coming in because of that automaticity, right? And so you see that with the SA node, the AV node, and you can see this to a limited extent in the some of the Purkinje fibers of the ventricles if all of the other pacemakers have failed. All right. Any questions so far? Anybody have any questions? Okay. Got something in chat. Let me address that. All right. So now let's talk about how we can monitor the movement of all these ions. And so essentially what you get is when you have charged particles being separated, you have potential energy. That's essentially potential energy. So think of like water behind a dam, right? And then when the water flows through the dam, right, that's kind of like electrical current. That's like ions flowing into and out of the cells. You get a little electrical current. And so the change in potential energy, you're going to have a change in the potential as the ions are flowing into and out of the cardiac cells. And we can actually monitor this. And this actually started back in the 1800s, and people would put people, we would take people and we put their arms and legs in bathtubs of salt water, and we would hook those bathtubs up to voltmeters, and we'd see that the voltmeters would change, right? And then somebody got the bright idea, well, let's take a voltmeter, right? So let me draw a little voltmeter here. And maybe I have a tub here, and I have a tub here, and I put a hand in one tub and a hand in another tub, and this is salt water, right? And the reason that it's real salty water is the ions allow for conduction to occur. All right. And then I take a wire and I connect that to one part of the voltmeter and then another part of the voltmeter. And then what I'll do is I'll attach, so I'd have like a little needle that move up and down. But what I'll do is I'll attach that to some string. And then on the end of the string, I'll have a little fountain pen. And then what I'll do is I'll take some paper. I'll draw a strip of paper here. And I'll move that paper, say, in this direction. And what'll happen is, as the potential, as the voltage changes, that pen is going to move back and forth. And as the paper goes across that pen, it's going to draw a waveform on the paper. And that's how we initially started monitoring the initial experiments on ECG monitoring. And this is actually a gentleman who kind of pioneered this. It was a guy by the name of Einthoven. Him and other people going back into the late 1800s. And this is actually where the term EKG comes from. The K is cardiogramma, which is Germanic. And then when it arrived to the new world, quote unquote, in the United States, the anglicized version of cardiogramma is C instead of K, and so that became ECG. So both are appropriate terms, but that's where the term K comes from, is historical from the Germanic linguistic language and the spelling of cardiogram, with a K instead of a C. All right, and so those early experiments are what led ultimately to our contemporary use of monitoring. And so what Einthoven did was I'm going to erase this. He, instead of using bathtubs, we kind of we got a little fancier. And what we did is we put electrodes, we attached electrodes onto the surface of the body. So the bathtubs were actually the original, the OG electrodes. But what Einthoven did was, let me draw a person here, or some facsimile of a person. All right, so you've got arms here. And legs here. So what Einthoven did was he said, okay, well, let's attach an electrode. So I'll attach an electrode, say here, and an electrode here. So here is an electrode on the right arm, and here's an electrode on the left arm. Okay. And then what he said was, I'll hook those electrodes up to that voltmeter and get a tracing. Now the modern monitors, let me ask you a question. Do we have to worry about ink, about refilling ink in modern or contemporary monitors? What do you all think?
Just paper.
No.
Why not?
Isn't it like a
Monitors
carbon
are
paper?
thermal.
What about the paper?
Is it carbon paper?
There's no ink.
No, there's no ink.
It's a thermal paper that just
Yeah. So instead of attaching the voltmeter to a fountain pen, an ink pen, the voltmeter is attached to a hot pen, right? And it has the end of the pen heats up, and then as the paper goes across, right, it essentially, that is heat sensitive paper, it essentially burns the tracing into the paper, and that way you don't need to use ink, right? So that's the contemporary way of doing it, but it's still conceptually the same thing. All right, so I'm just going to go through this real quick, and I am mindful that we're going to come up on our first break. So you attach an electrode here, and then whenever you're dealing with electrical systems, you also need a ground. And so this is just the symbol for ground. And ground traditionally is the right leg. So the electrode on the right leg acts as a ground for the system. And what he did was he said, okay, what I'm going to do now is I'm going to attach an electrode on the right arm, an electrode on the left arm. And then what we're going to do is we're going to make one of these electrodes what we call negative, and one of these electrodes positive. And the positive electrode, what you want to think of it as an eyeball. So the positive electrode is an eyeball. So the positive electrode's essentially an eyeball sitting on the left arm, and it is looking at signals coming toward it. So whenever a signal goes from a negative electrode to a positive electrode, what you will see is you will see the waveform go up. That's what we call positive deflection. And then if you see a signal going away from the positive electrode or going toward a negative electrode, you will see it go down. And that's what we call negative deflection. So positive deflection is a signal moving toward the positive electrode, and negative deflection is moving away from the negative electrode. And this view that is produced, this difference between a positive electrode and a negative electrode, is what is referred to as a lead. So a lead is the view that is produced between two electrodes. Is everybody okay on the difference between a lead and an electrode? All right. So we're going to stop here and take our first break. We actually went a little long. I'm sorry about that. It's 9:35. Let's meet back up at 9:50. I'll see you all back at 9:50. All right. So before I move on, are there any questions over anything I've covered so far? That's just a foundation. So we're gonna go a little deeper now. We're gonna take a little deeper dive into this. So I just want to make sure I haven't lost anybody. Okay. All right. So now what we're gonna do is we're gonna talk about electrodes and leads in some detail. So let me go back and share on the iPad with you all. There we go. All right. So I'm going to talk about the three what are known as limb leads. The three limb leads. So when we put electrodes on, we'll put an electrode on the right arm, an electrode on the left arm, an electrode on the right leg, and an electrode on the left leg. All right. And from these four electrodes, we can get three leads. And remember, the right leg is the ground, so it's not really used. So it's really just the right arm, and left leg. All right. And so the way that this works is the right arm becomes a negative electrode, and the left arm becomes a positive electrode. And so it looks in this direction. I'm going to draw an arrow there. And the lead that comes from RA to LA is what we call lead 1. All right. And because this is the first lead, we can imagine that this is going to form a kind of circle. We can form a circle around the heart using different leads to look at different parts of the heart. And because this is the first one that was kind of discovered, if you will, this lies at 0 degrees. So lead 1 lies at 0 degrees. It's just arbitrary where we want to start the circle. We could have started it anywhere, but this is just how it happened for historical reasons. That's lead 1. The next lead that we can develop is what's called lead 2. And lead 2 is where the right arm is again negative, and the left leg becomes positive. So we can take a look at the RA to LL, and that becomes another lead. And that becomes what we call lead 2. All right. And then the third limb lead is where LA is negative, and these electrodes can be positive or negative depending on the lead. And so because you have actual physical electrodes on the body, and these electrodes have a negative, there's a negative one and a positive one, the limb leads are also known as bipolar leads. Right? They have a negative and positive, and the electrodes can be negative or positive depending on what lead you're looking at. That is unique to these three leads. And the third lead is where LA is negative and LL becomes positive, and that is going to look in this direction here, and that is what we call lead 3. And I've drawn the heart in the middle. And so essentially what we've done is we have made a triangle around the heart. These three leads make a triangle around the heart. So you've got lead 1 here, lead 2 here, and lead 3 here. So that's 1, 2, and 3. And in fact, they make an equilateral triangle. And remember, from geometry, from basic Euclidean geometry, idealizing everything to flat spaces, right? The sum of all angles inside of a triangle have to come to 180 degrees. And if you're talking about an equilateral triangle, that means that the angle of each of these is going to be 60 degrees. So the angle of each of these three leads, right, they're going to be, the angles are going to be 60 degrees from one another, making an equilateral triangle around the heart. And so remember, let me draw the heart again. We've got the heart here. We've made an equilateral triangle. And remember, we're going to start our circle around the heart here on lead 1 at 0 degrees. And I'm going to move in this direction. So 0 degrees would be here. 90 degrees would be down here, plus 90. And then 180 degrees would be up over here. All right. Let me just draw a line to separate this. There we go. So 0, 90, 180. I've made a half circle around the heart. So we said that lead 1 sits here at 0 degrees, right? Lead 2 is coming down here. All right. Everybody see that okay? And lead 2 is going to be pointing at 60 degrees. So remember, 90 degrees would be here. And then lead 3 is pointing in this direction. And so lead 3 is going to be pointing at 120 degrees. So 0 degrees lead 1, 60 degrees lead 2, and 120 degrees lead 3. Everybody okay with that so far? So lead 1 is at 0 degrees, lead 2 pointing at 60 degrees, and lead 3 is pointing at 120 degrees. Is everybody okay so far? All right. So now what we're going to do is we're going to get a little more complicated, and it's going to be there's going to be a little math here. So these three leads are great, and oftentimes lead 2 is frequently used because if we look at the electrical activity of the heart, this is the SA node here. This is the AV junction, the AV node. And when the SA node depolarizes, the top part of the heart depolarizes, then it goes down the bundle branches and then depolarizes out like this. And so a lot of the electrical activity of the heart is moving in the general direction of lead 2, from the top of the heart down to the bottom of the heart. So the top right to the bottom left, right? And because the electrical activity is in line with lead 2 is often used as a lead to look at the cardiac rhythm. Okay. But what we want to ultimately do is we want to ultimately be able to look at multiple areas of the heart. So with the limb leads forming this triangle, and this triangle is referred to as Einthoven's triangle. Using the bipolar limb leads, we can look at the heart in 60-degree angles. But wouldn't it be nice if we could have other leads that looks at the heart, but maybe cuts those 60-degree angles in half, right? Is there any way we could get some other leads into the mix and narrow that down and take some additional slices of the heart? And actually, yeah, we can do that. And this is actually related to a mathematical principle known as Kirchhoffs Law of voltage. Kirchhoffs Law of voltage. And essentially what Kirchhoffs Law of voltage says, we don't have to derive it here, but essentially what it says is the sum of potential differences around a closed loop equals 0. They all cancel out. All right. And essentially what we've here with Einthoven's triangle is we've made a loop, right? We have made a loop around the heart with these 3 limb leads, these bipolar leads. And from this concept is actually something referred to as Einthoven's law. And essentially what it says is, it says there's a relationship between these 3 leads here, right? Because it's an equilateral triangle around the heart. They're all at 60-degree angles to one another. And so the relationship is as follows. If you take lead 1 and you add it to lead 3, that gives you lead 2. 1 plus 3 equals 2. That's the relationship. And from that relationship, we can develop additional leads. All right. Now, these additional leads, these additional leads are what we call Goldberger's leads. So Goldberger came along and he added on to the foundation that was developed from Einthoven's triangle. So Goldberger came along and he said, hey, using Kirchhoffs law and Einthoven's law, I'm going to manufacture some additional leads. And these leads are not bipolar though. And you'll see that it's actually kind of weird what we do with these leads. So what Goldberger said is, hey, what if I made the leads themselves into additional leads? And the way we can do it from a very mathematical standpoint is what we call vector summation. And so vector summation, it very basically, if I just draw a vector is something that has a direction and a magnitude. So if let's say I have an arrow like this, so that's a vector. So the direction the arrow is pointing is the direction, and then the length of the arrow is the magnitude. And then I have another vector here. What I can do is I can add these vectors up, right? So I can take this vector here and add it to this vector, and I can create a new vector. So if I add the top vector and the bottom vector, I'll get a new vector that'll look something like this. That's the new vector when I add those, right? And that is essentially what we're doing with these Goldberger leads, is we're adding, right? We're taking components of the limb leads, the bipolar leads, and we are creating a new set of leads, all right? And so what Goldberger did was he said, okay, well, let me just start over here. So I've got lead 1 here, got lead 2 here, and I've got lead 3 here. So what he said is, you know what? Let me take one of these leads, one of these electrodes. All right, so I've got, this is the right arm, this is the left arm, and this is the left leg. So what he did is he said, okay, let's take the left arm and make that positive. All right, left arm, make that positive. And then what we will do, because the limb leads are bipolar, I can look at them in different directions and I can add them together and average them out. So what he did is he said, okay, well, let's do this. Let's take the right arm and the left leg, and then we'll add a little bit of resistance here and a little bit of resistance here, like 5,000 ohms. All right. And essentially what we're going to do is we're going to take the right arm and then we're going to add it to the left leg and then divide by 2. Essentially, we're going to average them out, right? And what that does is that makes a virtual electrode. So the average of RA and LL becomes an electrode. It is converted into another electrode. And what that does is that creates a new lead where this, the RA plus LL averaged out, becomes essentially a negative electrode. It's a virtual one. And then I have negative going to positive. And now I have created a new lead pointing toward the left arm. And because we did this averaging, we had to augment the limb leads to create the new lead. We call these leads augmented leads. And this is AVL, augmented vector left. It is a lead that is shooting up toward the left. All right. I can do the other thing on the other side, and I'll do that in a different color. So what I can do is I can take the left arm and the left leg, and I can do the same thing here, right? All right. I can do the same thing. So I can go left arm plus left leg and essentially average it out. And that will create a new virtual electrode. And then I can make the right arm positive and then this negative, and then I will create another lead going up toward the right arm. And because I am augmenting the limb leads to create that, we call that augmented vector left or augmented voltage left. All right. So it's AVL or AVR, excuse me. It's going to the right. So we call that augmented vector right. We already talked about augmented vector left. So that's AVR because it's going to the right arm. And then finally, what I can do, all right, is why not do this pointing down? Why not do this pointing down? And let's do this in a different color. So why not take the RA here, put a little resistance in, the LA, put a little resistance in, and create a lead, a virtual electrode here. That is the sum and the average of the RA and the LA. And then make the left leg the positive. And so I have created another augmented lead that is pointing down toward the foot. And that is referred to as AVF, augmented vector foot, or augmented voltage foot. So I have created 3 additional leads. Now, because these leads use a virtual electrode, they are not bipolar like the limb leads. The limb leads are bipolar. There are actual physical electrodes, but one of the electrodes of these augmented leads is a virtual electrode, right? And then the other is an actual. So these are referred to as the augmented or Goldberger's leads, but they are not bipolar. All right. Is everybody okay with that so far? And so I have created 3 new leads from the limb leads, AVR, AVL, and AVF. And they split the difference. They split the difference between the limb leads. So remember, the limb leads are all at 60-degree angles. And now I'm splitting the difference at 30-degree angles with these augmented leads, right? So remember, our angles, lead 1 is at 0, lead 2 is at 60, and lead 3 is at 120. So let's put that in. I'll do that in a different color here. So lead 1 is at 0 degrees here. Lead 2 is at 60 degrees here. Lead 3 is at 120 degrees. Well, let's look at these augmented leads, right? What angles are they making? Well, let's look at the AVR here. All right, AVR going up this way, and then AVF going down. So AVF is shooting straight down at 90 degrees, right? That's the easy one. AVL is up here. All right. And then AVR is up here. And so you can see that these are splitting the angle further down, right? Subdividing it further down. And so now you have 30-degree increments or 30-degree angles instead of just 60-degree angles. And what you're seeing here, though, is with Einthoven's angle, with Einthoven's leads, with the limb leads and the augmented leads, you're only looking at the heart in one plane, right? So you're only looking at the heart in one plane. And I guess what I should do is let me just fill in the angles, right? So for example, AVL would be shooting toward 30 degrees, right? And then AVR would be shooting toward 150 degrees, right? There's your 30-degree increments. So 150 degrees is up here because remember, it's moving in this direction, and then 30 degrees over here because it's moving in that direction. So 30, 60, 90, 120, 150. But you're only looking at the heart in one plane, right? And what plane are we looking at the heart in?
From the front?
Yep, for a frontal or coronal plane. Good. So I'm only looking at the frontal plane. So you can imagine, let me go up here at the heart. You can imagine the heart imagine that the heart is actually coming out of the screen at you. So the heart's a three-dimensional object. And so imagine that it's popping out of the screen, coming out at you, right? Everybody okay with that? So what plane would that be? The plane that's coming out of the screen at you. So the frontal plane is essentially what the limb leads and the augmented leads look at, but the heart popping out at you would be what plane?
Transverse.
Yeah, transverse plane, right? We haven't looked at the heart in the transverse plane yet, right? And so what we can do now is, now that we understand things just a little bit, another thing that we can do with the limb leads, moving down here, is, let me just draw Einthoven's triangle again. So here's lead 1. Here's lead 2. Here's lead 3. Okay, so what we can actually do is, if you look at this picture here, do you see where all of the leads kind of cross? This is not a perfect drawing, but all the leads should kind of cross over and cancel out at a point right here in the center of that triangle. The very center of that triangle, everything kind of cancels out and it could become 0. And this center is actually something referred to as Wilson's central terminal. And we can actually use that central terminal and turn that into a virtual electrode as well. And the way the monitor does that is it takes input from all 3 limb leads. So we take, let me do that in a different color here. So we take input from the right arm, add a little resistance, and then we take input from the left leg, add a little resistance, and then we take input from the left arm, add a little resistance, and then we take all that input, we add it together, and that, remember when we talked about Kirchhoffs Law of voltage, right? When you have a loop around the heart, the individual voltages cancels out, and that creates a new point right in the middle of that triangle where it's 0, right? So you have a 0 point, maybe and that will functionally act as a negative electrode. All right, and so that gets connected into the monitor as a negative electrode. And then all we need to do is we need to place additional electrodes around the heart, right? Around the transverse plane of the heart. So we'll place an electrode. So this is the heart here. And you want to imagine this is popping out at you. I'll place an electrode here, an electrode here, electrode here. Right? I'll place 6 additional electrodes, and those electrodes will become positive. And using Wilson's central terminal as the negative, I can create 6 additional leads. And this is what we call V1. And then this is what we call V2. And this down here is what we call V3, V4, V5, and finally V6. So Wilson's central terminal acts as the negative electrode. It's another virtual electrode. And then the 6 electrodes we put on the chest act as the positive electrode. And you now have 6 different leads. And so the limb leads are the bipolar leads. They're actually bipolar. They have an actual physical positive and negative electrode. All right, and those are leads 1, 2, and 3. And then your augmented leads, okay, use combinations of the limb leads to create negative electrodes. And then add an actual limb lead or an actual limb electrode to be the positive electrode. And those are what we call the augmented leads, AVL, AVR, and AVF. And then finally, using Wilson's central terminal as a negative electrode, we place 6 more electrodes on the patient's chest around their heart, and we call those the precordial leads. And those include V1, V2, V3, V4, V5, and V6. All right. Now, the limb leads are the only ones that are bipolar, and the augmented and the precordial leads use virtual, right? Use a virtual electrode and an actual electrode. And these 10 electrodes that we place on the body form 12 different leads. And this is what we call a 12-lead ECG. So if I go and we take a look at a 12-lead ECG, the 12-lead ECG is actually configured, standard configuration, okay, because this can differ a little bit, but this is a standard configuration. It starts off with your limb leads, so leads 1, 2, and 3, right? So those are Einthoven's triangle. And then it moves on to the augmented leads, AVR, AVL, and AVF. And then finally, the precordial leads, V1, V2, V3, V4, V5, and V6. That's why a standard 12-lead ECG is set up in this configuration. Is everybody okay there? Is everybody okay there?
Fantastic.
Yes, sir.
All right. So I know this may be a lot for some of you, and I imagine a lot of people were like, oh, well, I'm just going to learn what a P wave is and all this and that. So there's a lot of foundational stuff I just went over. I just want to make sure you're okay. Everybody's okay. All right. So now let's make this a little less conceptual, right? So let's talk about what we actually see on the monitor. All right. So what we're actually seeing on the monitor, just here. All right. So that's just a review of everything that we talked about. Just as a reminder, a lead, again, is a difference between the negative and a positive electrode. And when you have actual electrodes, we call those limb leads. And then virtual electrodes can either be augmented or precordial leads, depending on what you're looking at there. And remember, whenever the signal is moving toward the positive electrode, you're going to get positive deflection. And whenever it moves away from the positive or toward the negative, you're going to get negative deflection. All right. And just a review here, proper electrode placement. This is critical because remember, these angles, right, to get these angles, to get the proper waveforms on the monitor, you need to make sure that your electrodes are properly placed. So just a review, the RA, right shoulder and elbow, LA, left shoulder and elbow, RL, above the right ankle to below the torso. So it literally needs to be on the leg, right? Because we want that central terminal to be more or less in the center of the heart. And so if your lower electrodes are high up on the leg, right, that's going to move Wilson's central terminal up, and it's going to kind of alter the waves a little bit. Above the left ankle to below the torso, LL, and then V1, right, V1 is going to be the fourth intercostal space to the right of the sternum. And don't worry, we'll be practicing this in lab, getting good proper placement. V2 is just going to be to the left of V1, fourth intercostal space to the left of the sternum. And then V3 midway between V2 and V4. So V4 is going to be at the fifth intercostal space, mid-clavicular line. V5 anterior axillary line, same level as V4, and V6 mid-axillary, same level as V5. All right. And then there are some modifications like V4R and what we call the posterior leads, but we will talk about those later on. All right, so that is proper lead placement, and we will practice appreciating those landmarks and getting 12 lead ECGs and rhythm strips in lab tomorrow. Hold on here. Why do some put limb leads on the abdomen? I don't know. You really shouldn't do that because you are, well, I know why, because you can get artifact from muscle spasms and things like that. And sometimes people have, amputations and things of that nature, but you really want those electrodes, in it as proper position as possible, because you want Wilson's central terminal in the middle of the heart, so your precordial leads will turn out okay. And you also want your augmented leads to have the right angles and to be looking at the right areas of the heart. Yeah, so, but that is why some people place electrodes in different areas. You want to place them as close to where they should be placed anatomically as possible. All right, so before we take our first break, I do want to talk a little bit about the ECG paper and how it is divvied up, so to speak. All right, so this is standard paper. So what you have is you have X and Y. So on the Y-axis here, going up and down, this is the potential, the electrical potential in millivolts. And on the X-axis here is going to be time. So change in voltage as a function of time is actually what we're looking at. And the standard setting for this monitor, the standard movement is 25 millimeters per second. Some people choose to go a little faster, but this is standard, and this is what we standardize things at. So the paper will move at 25 millimeters per second. And what that means is you can divide the paper up into little chunks. So the tiniest of boxes, the tiniest little box here, I'll circle that in red, is 1 millimeter. 1 millimeter by 1 millimeter. So those are 1 millimeter by 1 millimeter boxes. And so each millimeter, so 1 millimeter in the X direction equals 0.04 seconds. And 5 millimeters is going to equal 0.2 seconds. And I've got 5 millimeters in each of these larger boxes. So these larger boxes are 5 millimeters by 5 millimeters. All right. And then 5 boxes, all right, is going to be what? 25 millimeters, which is going to equal 1 second. Now on the Y-axis, it's a little different, but each of these boxes, each 5 millimeter section is 0.5 millivolts. So each millimeter is, so this is on the X-axis. On the Y-axis, each millimeter equals 1 millivolt. All right, 1 millivolt of deflection. All right. 3 seconds would be 75 millimeters or 15 boxes. And typically what you're going to get on a printout is you're going to have a spike. You can see these little spikes here. You're going to have a spike every 3 seconds. So you've got 3 seconds here, 3 seconds here. Okay. And 150 millimeters is going to make what we call a 6-second strip. And this is typically what we use for rhythm analysis. All right. Rhythm strip analysis is a 6-second strip. Now, 12 lead ECG is used for something a little different, but when we're looking at someone's cardiac rhythm, we're going to use a 6-second strip. Some 12 lead ECGs may have a 6-second strip or larger built into them, and that's fine, but some don't. All right, so I think what we're going to do is we're going to take another break. Any questions before we take another break? Okay, I've got 10:30. I will see you all back at 10:40. I'll see you in 10 minutes. Okay, welcome back, everyone. All right, any questions before we move on? All right. So I just want to take a quick minute to make sure that everybody's okay on the direction that the various leads are pointing. So I've just drawn a little diagram here. So I said what we're doing is we're kind of making an imaginary half circle around the heart, starting at 0 degrees. So starting at 0 degrees right here. So lead 1 is pointing directly at 0 degrees. And then lead 2 is pointing in this direction here at 60 degrees, whereas lead 3 is pointing at 120 degrees on this half circle. All right. And then what we do is we make the augmented leads. And so AVL is pointing up and toward the left between 0 degrees and 60 degrees at 30 degrees. And then AVR is pointing up to the right above 120 degrees. So AVR is pointing up here at 150 degrees. And then AVF is pointing right down toward the foot, the right foot, right here at 90 degrees. All right. So you've basically sliced this circle into little 30-degree segments. And that's what these leads are looking at, little 30-degree sections, if you will, or this 30-degree angle between each of the leads, starting at lead 1, AVL, lead 2, AVF, lead 3, and AVR. All right. So I just wanted to solidify that comment or that concept there before we move on. All right. So moving on. So when we go to our monitor and we do ECG analysis, when we turn the monitor on and we just print off a single lead rhythm strip, oftentimes that's going to be lead 2, that's going to be in what's called non-diagnostic quality. And you will actually see the frequency filtration is going to be different. And so non-diagnostic quality, or what we call rhythm strips, have filters that are going to potentially remove important features in order to focus on rhythm analysis. And so the frequency response for a rhythm strip is generally going to be between 0.5 and up to 50 hertz. Typically 0.5 to 20 or 0.5 to 50 hertz. Okay. That's a frequency response. It's fairly limited. Whereas if you put the monitor in 12 lead mode, it will print off what's called a diagnostic strip. And that will allow for more information and a clear analysis of segments and intervals at the cost of being vulnerable to artifact because the frequency response is much larger, as you can see there, 0.05 all the way up to 150 hertz. So if we actually go and we take a look at this 12 lead here, down at the bottom, you can see, right, 25 millimeters per second, 0.05 to 150 hertz. So we know that this is a diagnostic quality, right? And you can actually see how it's a little bumpy here. The baseline's a little bumpy. It's actually getting some artifact. So it's very sensitive, but it's going to be more prone to artifact when in this mode. And that's sometimes like when you're getting a 12 lead on somebody and you're looking at the monitor and everything looks okay, and then you print the 12 lead off and you're like, where the hell did all this artifact come from? That's why, because the 12 lead is allowing more information in, and so artifact is going to be a bigger problem there. All right. So with that in mind, let's just talk about common types of artifact that you can see. All right. So these are some of the most common types of artifact that we run into. So first and foremost, 60 cycle interference. And 60 cycle interference is actually when the monitor is picking up alternating current electricity from electrical machines, machinery, lights, fluorescent lights, those kinds of things, right? And so you can see this very thick black baseline oscillating at 50 cycles a second, which is AC, alternating current, alternates 50 times a second, right? Or 60 hertz. Right? So things like AC current, lights, various machines. Sometimes you have to unplug the monitor to get this to go away, right? And so you see this continuous, regular, thick baseline at 60 cycles a second oscillating. Another common artifact is muscle tremor and contraction. So if you have skeletal muscle that's contracting, you will get these large, thick, irregular lines or little bursts of activity happening, right? That's classic muscle artifact. And then the other major kind of artifact that you get is what we call baseline drift or respiratory artifact. And this is associated with breathing. So you can see as the person is inhaling and exhaling, you can see this kind of this waviness occurring on the monitor. So when you have interference, you need to identify interference and artifact, and then you need to take steps to negate it in order to obtain the highest quality ECG possible. All right. So that's artifact. All right. So now let's move on to actually identifying what we should normally see. And we're going to start with the rhythm strip first. We're going to get comfortable with rhythm analysis, and then we will move on to 12 lead ECG analysis. All right, so let's just talk about what we normally want to see on a rhythm strip. And we want to normally see a sinus rhythm. And a sinus rhythm is a situation where the SA node is in control. The SA node is acting as the primary pacemaker. And you have three major sinus rhythm. You have something called normal sinus rhythm, or NSR. There we go. You have something called sinus braid. Sorry, I got to put my glove on here. It's picking up my my palm. Palm rejection doesn't work very good on this one. So there we go. You've got sinus bradycardia and you've got sinus tachycardia. In all three cases, the sinus node is in control. So first thing we want to do is we want to be able to identify normal complexes and intervals. So when we look on the ECG, this first bump that you see here is what we call the P wave or the primary wave. And this is the atria depolarizing. the atria depolarize. All right, so the SA node fires, and then the atria depolarizes. And then you have this little pause right here. This little pause after the P wave is that pause that I talked about earlier, right? So the atria are actually contracting right here, right? Contraction doesn't happen immediately with depolarization. It takes a little bit of time. So you have that little pause there to allow the atria to contract and pump blood down into the ventricles. All right. So the time interval from the beginning of the P wave to the beginning of the QRS complex, this little interval here, is what we refer to as the P to R interval, or the PRI. And the normal P to R interval is 0.1 to 0.2 seconds. And remember, each little box, each of these little boxes here is 0.04 seconds. So a normal P to R interval should be between 2.5 to 5 of the small boxes. All right, 2.5 to 5 of the small boxes. Should be no greater than 5. So greater than 5 small boxes is what we call a prolonged P to R interval. All right, and then the little downward deflection you see here is what we call the Q wave. All right, so you're going to see the Q wave, and then you're going to see the R wave. That's the upward deflection, and then you're going to see the S wave, downward deflection. So the Q wave is the first downward, the R wave is the first upward, and then the S wave is the second downward. And collectively, they form the QRS complex. Now, sometimes you may not have a Q wave. You'll just have an upward deflection. And so you might see something like this, where you just have an R wave, right? And this is actually something called an RSR complex, right? And you don't actually have a Q wave, and that's actually not necessarily okay. In fact, this is something called an RSR prime complex, and that is to say that this little guy here is a little taller, and so that's the prime. That's what this little apostrophe means here, prime. All right, but we're going for normals right now. So you've got the Q, the R, and the S complex, and that is ventricular depolarization. And then the S wave should return to baseline and flatten out at baseline, and that's called the ST segment. And then this flattened area here is something referred to as the J point. And that will become important later on when we talk about 12 lead ECGs. So you got the P, the QRS, and then you've got the T wave here. And the T wave is ventricular repolarization. The ventricles are repolarizing. So let me ask you a question. Why do we not see atrial repolarization? We see atrial depolarization here in the P wave, but why do we not see atrial repolarization?
Because it's hidden in the QRS complex.
Yeah, because the atria will repolarize while the ventricles are depolarizing, and so it's just hidden. Good. And then you may occasionally see a slight small bump after the T wave, and these are referred to as U waves. And U waves can be caused by, they may just kind of be a normal thing. They may be indicative of electrolyte anomalies like hypokalemia, or you could have just a little bit of after repolarization or depolarization of the papillary muscles that the chordae tendineae of the heart valves are connected to. So if you're worried about electrolyte anomalies, then U waves may be more of a concern. You're not always going to see them though. Oftentimes you won't. Now the QRS complex also has a normal duration, and the normal duration of the QRS complex is less than 0.1 seconds. All right. So 2.5 small boxes or less. So you can see I've got one here and then half. So I've got 1.5 or 0.08 seconds there for the QRS duration. If the QRS is wider than about 0.12 or 3 small boxes, that is generally considered abnormally wide and may be indicative of a problem. So that is the normal PQRST complex that we should see on the rhythm strip. So now let's talk a little bit about rhythm strip analysis. And this is a systematic approach that we want to take when we are confronted with a rhythm strip. All right, so step one, what is the rate? Okay, what's the rate? Step two, what is the rhythm? Is it regular? Is it regularly irregular? Or is it irregularly irregular? Those are the common rhythms: regular, regularly irregular, or irregularly irregular. Step three, is there a P wave for every QRS and a QRS for every P wave? If you have more P waves than QRSs, that's a problem. And if you have more QRSs than P waves, that's a problem. Every P wave should have exactly one QRS. Step four, what is the P to R interval in seconds? Step five, what is the QRS interval or duration? And then once you gather all of your information, right, you get your information first, then you diagnose. What is your analysis? All right. So when we say that someone has a normal sinus rhythm, we're saying that everything is normal. The rate is normal. The rhythm is regular. There's a P for every QRS, a QRS for every P. The P to R interval is normal. The QRS duration is normal. And we are going to analyze that or diagnose it as a normal sinus rhythm. Now, sinus bradycardia is everything being normal except the rate. And the rate will be less than 60 in an adult, at least. Sinus tachycardia is going to be everything normal except the rate will be above 100. All right. And those are the three sinus rhythms. So let's take a look at some examples of these sinus rhythms. But first, how do I figure out rate and rhythm? So there are different methods. So remember when I talked about a 6-second strip? So a common method is taking a 6-second strip. All right, so this is 6 seconds here. Count the number of R waves in a 6-second interval. So you see how I have 7 R waves here. Multiply that by 10. So this is 6 seconds, right? And if I multiply 6 seconds by 10, that's going to give me a minute, 60 seconds. All right, so the number of R waves in 6 seconds multiplied by 10 gives me the rate per minute. So this would be a rate of 70 per minute. Now, if the rhythm is very irregular, what you can do is you can do what's called the boxes method. So you find an R wave that lands on one of these big boxes, and then you count how many big boxes between the next R wave. If it is one box, So if this was an R wave and this was the other R wave, so there's just one box between R waves, that would correspond to a rate of about 300 a minute. However, if this is an R wave and then there were two boxes between R waves, that would be a heart rate, or a rate rather, of about 150. If, however, this was an R wave and this was an R wave here, so three boxes, that would give me a rate of 100. Four boxes, 75, five boxes, 60, six boxes, 50, seven boxes, 43, eight boxes, 37. All right. So let's just practice that right here. So I have a 6-second strip. So here is a box, and there's my R wave on that box. So I've got one box here, two boxes, three boxes, four boxes, and then the next R waves, that's 4.5 boxes, right? So that's going to be between 75 and 60, or 65 and 70. And then if I do the count the number of boxes, or the number of R waves in 6-second strip, I've got 1, 2, 3, 4, 5, 6, 7. 7 times 10 equals 70. So you can see that the rates align fairly well. Now, the more irregular the rhythm, the harder the boxes method is going to be. And so you may have to rely more on the 6-second counting R waves in 6 seconds. That's going to be a little more accurate. All right, so that's rate. What about rhythm? How do I determine rhythm here? Well, what you can do with rhythm is you can just do this with a sheet of paper. Take a sheet of paper and place the sheet of paper partially over. So here's a sheet of paper. Place it partially over the rhythm and draw a line with a pencil on one R wave and a line with a pencil on the other R wave. And then what you do is, let's see if it'll let me move this. You will move this over, this paper over. So I started here, right? And then what I'm going to do is I'm going to move the paper over, and I'm going to make sure that those line up. So the R's are all lining up. See that? And as long as it lines up plus or minus 1 millimeter, one small box, you can consider that regular. If they don't line up, or if they're outside off more than one small box, 1 millimeter off, then we say that that is an irregular rhythm. All right. So before we conclude lecture for the morning, let me give you some examples of the sinus rhythms. So here we go. Let's start here at the top. So start with the rate first. So I've got 1, 2, 3, 4, 5, 6, 7. 7 times 10 equals 70. So the rate is 70. The rhythm, R waves all line up. That's equal to that. So the rhythm is regular. I see a P wave, and I see a P for every QRS, and a QRS for every P. So I don't have extra Ps, I don't have QRSs. So that's yes. The P to R interval, I've got 1, 2, 3, 4 little boxes there. That gives me a P to R interval of 0.16 seconds, which is normal. The QRS is between 1 and 1.5 small boxes, or 0.04 to 0.06 seconds. So everything is normal. So we would call this a normal sinus rhythm. Let's move on down here to number 2. So let's look at the rate. So the rate 1, 2, 3, 4. The rate is 40. The rhythm, let me put a line here. And then a line here. Oops. And let me see if they line up. Yep. Yep. They all line up. So we would say that this is regular. The rhythm is regular. So the rate's 40. The rhythm's regular. I can see a P, a P, a P, a P, a QRS, 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 QRS. So there's a P for every QRS and a QRS for every P. Let's look at the P to R interval. I've got 1, 2, 3, 4 small boxes. It's 0.16 seconds, and the QRS complex is narrow. It's about a box and a half or 0.08 seconds. So everything's normal except the rate, which is less than 60. So we would call this sinus bradycardia. The sinus node is in control, but the rate is lower than the normal. And then finally, let's take a look at this rhythm here. All right, so the rate. So I'm going to count R waves. I got 1, 2, 3, 4, 6, 7, 8, 9, 10, 11, 12, 13 times 10 gives me a rate of 130. The rhythm, let me draw an R wave here and an R wave here. Oops. There we go. All right, that seems to line up. Lines up, it lines up. You can also use ECG calipers. They're like a little calipers with little needles on the end of them. And you can use those to measure intervals and to look for regularity as well. But a piece of paper works just fine as well. So the rhythm is regular. Oops. All right, so here's the P, here's the QRS and the T. Looks like I've got a P wave for every QRS and a QRS for every P. Yes. P to R interval. Let's see if we can zoom in even further here and figure out what the P to R interval is. All right, so here's the T wave, and here's the P wave. So the very beginning of the P wave here, 1, 2, 3, maybe 3.5 boxes. So 0.14 seconds or thereabouts. Oops. This says 0.16, but I think 0.14 is probably a little closer. The QRSs are very narrow, about a box, 0.04. So what's our impression here? Well, everything's normal except the rate, which is greater than 100. And so we would call this sinus tachycardia. All right. So that's our basic rhythm analysis. The other thing that I want to just briefly mention are the causes of. Yeah, could you turn your microphone off, please? Find out who that is. Someone had a hot mic. Okay, I think it went away. Okay, good. All right. So I just want to talk about just the common causes of dysrhythmias. So typically with sinus rhythms, a lot of it is going to be the balance of the autonomic nervous system, the sympathetic and the parasympathetic nervous system. So the parasympathetic nervous system is actually connected directly to the heart, the part of the vagus nerve. Whereas the sympathetic nervous system is kind of indirectly regulating by releasing epinephrine and, well, primarily epinephrine that acts upon the heart. And so when it comes to sinus bradycardia and sinus tachycardia, those are some of the common things that you're going to run into, autonomic nervous system. So things like pain, for example, pain, hypoxemia, illness and injury are common causes of sinus tachycardia, whereas increased vagal response can cause sinus bradycardia. And there's actually a really good table. It's actually table 17-3 in the textbook. I want you to reference that. It's on page 975, I believe, and it actually gives the list, a list of differentials for the common causes of dysrhythmias. And so you definitely want to review that, because those are some of the common differentials you want to be thinking about when we have what's known as a dysrhythmia or an arrhythmia. Really, dysrhythmia is the more accurate term, because arrhythmia literally means without rhythm. But most of what we're talking about are dysrhythmias, or abnormal cardiac rhythms. So today, for this lecture, we just want to be comfortable with what the sinus rhythms are. And then after lunch, for the second lecture, we are going to talk about abnormal or dysrhythmias occurring in the top part of the heart, what we call supraventricular dysrhythmias. So before I let you all go for lunch, are there any questions? Anybody have any questions? Because I know we've gone through a lot of content. No? Okay, so I've got, let's see here, about a quarter after 11.
Chris,
Yes.
are you gonna upload the morning half and the afternoon half in two separate videos?
Yes.
Or is it gonna
Yeah,
be one
they're
whole
going to
thing?
be, no, they're going to be two separate videos.
Okay, cool.
Yeah, so
Thank you.
what happens is, yeah, as soon as I end this, when I hit end on this, it will begin uploading to the cloud as its own file. So this will be a file, and then the afternoon will be its own file, and I'll label that as I get those, as I'll get an email that says the upload is complete, and then as I put those links in for you all, I'll label the lectures so you know what is what. No problem. Excellent. So it's about 11:15. So could we meet back up at let's see, 12:15. How about 1300? Can we meet back up at 1300? Does that work for everybody?
Yes, sir.
All right. Sweet. I'll see you all at 1300. Thank you so much.